Good afternoon to everyone present here with us today. This is Shriyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by your keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor. I would like to welcome a very renowned doctor, Padma Shri awarded Dr. Umesh Kumar Bharti. Sir is MBBS, DHM, MAE at State Institute of Health and Family Welfare, Department of Health and Family Welfare, uh, and also State of Institute of Health and Family Welfare at the Government of Himachal Pradesh. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is WHO Guideline on Rabies Prophylaxis. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
Thank you, Sharonji. Uh, so today I would go to the background of how changing WHO rabies prophylaxis guidelines. So how this happened? Because when pathophysiology of rabies virus after inoculation or bite is to seek a nerve ending that it can invade and advance centrally within an immune protected nerve. And if this happens within a week and before sufficient circulating antibodies appear due to vaccination, such a patient is likely to be doomed. So we know globally 60,000 people die. 30% of them die in India. Major barrier to seek prophylaxis, high cost of rabies immunoglobulin, and even vaccine, which are also in scarcity all over. So these are 150 countries where the rabies is endemic. Uh, so when I started working in in my district hospital on rabies, so my senior used to say there is no rabies in Shimla. So whatever protocol you make, that would be successful. So that drove me to to look whether we have rabies in Himachal or in Shimla particular. So I went to the district. I went to the medical college and saw the records. And from 2009 to 2017, there were 23 deaths due to rabies reported to Indira Gandhi Medical College Shimla. Out of which 13 were from district Shimla and rest of from adjoining districts. And surprisingly, 5 of these deaths were among those who were given vaccine but not the rabies immunoglobulin. Arrest is for not seeking post-exposure prophylaxis. So when later on in 2014, when I was transferred to municipal corporation, so there I got this brain of animals checked, and in we found that a pup, monkey, langur, Himalayan palm cybert, and 2 dogs in municipality were found to be rabies positive. So that confirmed that rabies is there well in our Shimla municipality, and we should not sleeping. You see this Himalayan palm cybert, and this is a pup brain, pup below 2.5 months. So you can imagine people don't vaccinate their pups before 3 months, but this pup is 2.5 month old, and brain is rabies positive. So we should vaccinate pups before bringing home, then at 3 months, and then every year. That should be the protocol. So, uh, sorry. So in 2008, just to make vaccine affordable to the patients, we devised a pooling strategy. So we issued a letter, CMO Shimla issued a letter to all the neighboring health institutions to give first aid to all the animal bite victims and send them for vaccination to a centralized place in district hospital. There we more patients were there, and we could pool the patients and pool the vials, because we used to tell the patients bring one vial, rest we would give free. Actually, that was not free. Suppose 4 people are coming, one vial each. So we would distribute one vial among the 4 by intradermal method, and keep the 3 vials for next visits to be distributed among all the 4 during subsequent visits. So that's why this cost of vaccination came down from almost 2000, more than 2000 rupees, to just cost of one vial, that is 350 rupees. So this way we made the vaccine affordable, and this spread to all the districts, and all district had pooling centers, and we have 90 pooling center in Himachal now. So later on the vaccine was made free by the district administration, because it was costing hardly 350 rupees or 200 rupees in a tender cost. So this is how we brought down the rabies death to subsequently quite down, say from 35 to hardly 15 or 16, because some people were still dying. And in 2014, what happened that due to non-availability of immunoglobulins, people were dying because they're getting a vaccine but not immunoglobulin. So then that was the time that when I thought what to do. We have made the vaccine affordable to the people. How to make this available, immunoglobulin available in the times of this scarcity. So we devised a protocol of only wound infiltration of immunoglobulins. That's how this beginning was done in 2014. So we used to infiltrate only wounds and not give immunoglobulin to the muscle as per the WHO protocol. So that was a new beginning, and that was very dangerous also, because people were telling me you are violating WHO guidelines, and you can be in a soup, otherwise somebody dies or something goes wrong. But by God's grace, everything was fine, and we succeeded in showing that only wound infiltration is required, and not the intramuscular injection of the immunoglobulins is not required. So that's how this first paper came out: local infiltration of immunoglobulin without systemic intramuscular administration, and alternate cost-effective approach of passive immunization against rabies. So this was a publication done very small, 269 patients, and luckily this was read by some of the WHO experts, and they dropped me a mail that your work is very good, and we want to know more data on this, because we at WHO is actively thinking of changing the prophylaxis guidelines. So that's how we continued with the immunoglobulin only wound infiltration, and this is the second paper that has a data of 7,000 patients. That is a very huge data. See this lady. She was bitten by a clinically confirmed rabies dog, and she came to our clinic and she was infiltrated thoroughly, and she was given vaccine doses also, and she survived. She's still surviving, along with her daughter. Both were bitten by a rabies dog. So then some experts told me that no, we don't agree with your protocol until you show us that lab confirmed rabies dog has bitten some people and they survived. So this is the list of those people who were bitten by the lab confirmed rabies dogs and they survived, and see the amount of hemoglobin. Some of them were given hardly 0.5 ml into the scratch. So very small amounts, 3 ml, 1 ml, 2 ml were given instead of giving 10 ml. So that's why huge saving of in the form of immunoglobulins, and huge saving in the form of cost. There was no reaction, no anaphylaxis. Patient compliance was very good, and life was saved. So this is see the perianal area, both legs of children. So all these children, all these patients have survived. So that's how. Not only this, we later on did this experiment in animals also, and the animals also survived. So you see this very small amount, majority were given 0.05, one drop of immunoglobulin. See, majority of the patients were given. And hardly one or two patients got the full dose, that who were bitten very badly and lacerated wounds. So, rig volume calculated by patient weight and infiltrated at the wound site with reminder administered intramuscularly as it is the old protocol. So we devised a dose sparing approach of only wound infiltration. That has been accepted by WHO as a new protocol. See the old by weight formula and volume by wound infiltration. Huge exponential decrease in the volume and money also. You see here. So pooling technique of Himachal used to maximize the benefit by calling the patient to centralized place for post-exposure prophylaxis. So in 2017, when we see that deaths were reduced from 35 per year to hardly one or two. That also in those patients who were not able to come to the clinic. So as the prophylaxis got free, see the patient load has increased throughout the state, and death rate came down, hardly one or two. So that's how we are heading towards a rabies-free state, and we see the reaction rate is very. There is no anaphylaxis with equine immunoglobulins, and reaction rate is hardly zero point 0.4, not even 1%. So these are the all low reaction rate. That's what is. So in 2018, when the new WHO guidelines incorporated everything in black and white, so we were the first state in the country to issue these guidelines to adopt WHO guideline 2018, that was dose sparing, cost sparing, and life saving. So this letter was issued by the Director Health Services. And then another publication was there made. You see, out of 7,000 patients, more than 1,500 got just zero point 0.1 ml or less than that of immunoglobulins infiltration into the wounds. So that shows that immunoglobulin given into the wound carries a value and no use of giving immunoglobulin intramuscular. So this is the third publication on this. Wound-only injection of rabies immunoglobulin saves lives and costs less than $1 per patient by pooling strategy. So now we have adopted this new WHO protocol of 3 injections of vaccine on day 0, 3, 7, and have immunized more than 200,000 people by today. So these are 90 polling centers in Himachal working, and this is the feasibility of WHO recommended 3-visit fractional dose intradermal rabies vaccination regimen, that is known as IPC regimen by WHO, and only wound infiltration rate in rabies post-exposure prophylaxis to 1,84,955 patients. This evidence from India. This is the evidence from Italy. You can download this from YouTube and see how we infiltrate the wounds, how we infiltrate the scratches, and how we give the vaccine intradermally, how the bleb is formed. Everything you can see download from this video. So these are the new guidelines, Government of India guidelines, and see these are this is the infiltration. So technology can help no, in low cost thermostable dissolving intradermal microneedle rabies vaccine patches need to be made. So if globally we shift from intramuscular to intradermal, we would save $110 million. Similar $110 million will be shifted only wound infiltration of immunoglobulins. So these are the new guidelines that has been prescribed by WHO. I don't know why it is fluctuating. So saving cost and more lively. 1 week rabies post-exposure prophylaxis, a high throughput rabies prevention center in Karachi. These are these centers foreign news that has followed the guidelines. And now these are the more rabies endemic states. And rabies deaths are comparable to hepatitis B. So we want universal immunization program to carry this rabies prophylaxis. I'm sorry, it's not moving. So we did this infiltration in animals also, and all the animals survived: cow, buffalo, horses. So this protocol is very effective and life-saving, and not only in human beings but in animals also. So this is what we are saving lives of animals, giving intradermal vaccine to the cows, buffalo, and horses, and giving infiltration into the wounds, equine immunoglobulins, and sometimes less can be more, like intradermal vaccination and local rabies infiltration. So thank you very much.
Thank you, sir, for this wonderful presentation. We do have some question if you like to take that up, sir.
Yeah.
So the first question is, what are the recommended methods for PEP according to WHO guidelines?
That I'm coming in the second presentation. Just wait. What are the guidelines? Can I remove this presentation? Can I remove this presentation?
Sure, sir, you can.
Okay. So let me come to the WHO recommendations. So, what are the now new guidelines? Hardly described in 5 or 6 slides by the PowerPoint by WHO itself. So, what are the key recommendations? This position paper replaces the WHO position paper on rabies vaccine published in 2010, focusing on programmatic feasibility, simplification of vaccination schedules, and improved cost effectiveness. The recommendation concerned the two main immunization strategies, namely post-exposure prophylaxis and pre-exposure prophylaxis. So background I have already told you. Categorization, see WHO categorize into 1 to 3, but in Himachal we don't categorize into 1 to 3. We do spirit test. If we put spirit on a scratch and if it tingles or burns, then we take it as a category 3 even if there is no blood. So we give immunoglobulin as well as vaccination. So for us, there is exposure or no exposure. There is no categorization. So that's how we are doing prophylaxis in Himachal Pradesh. So human to human transmission of rabies virus is extremely rare. Uh, Only transmission to human is through transplants, corneal transplants in most of the cases. No case of human rabies resulting from consumption of raw meat or raw milk from a rabid animal has been documented. Rabies virus infection in rodent is very uncommon. No human rabies cases due to bites by rodent have been reported. So, what is the most important step in rabies prophylaxis? See, people always ask whether to give 3 injections, 4 injections, 5 injections, but they don't focus on washing of the wounds. So, most important step in rabies prophylaxis to prevent rabies is washing of the wound for 15 minutes under the soap, under the running water with soap, and making froth of it. So that soap and water washing is important, and application of any antiseptic alcoholic preparation. So this much can save 60% of rabies can be prevented by just wound washing with soap and water and application of antiseptic. So at least this can be done immediately by the people or by the health staff or by sub-center staff, and then refer the patient for injections. People, when patient comes to some lower institutions, people say, भाई हमारे पास वैक्सीन तो है नहीं, ऊपर चले जाओ. We don't have vaccine, go up to the higher institution. At least you have the soap and water. Wound washing is important. That's what I want to say. So that's what wound washing is important. Wound care is important. Series of rabies vaccine injection should be administered immediately after an exposure. PEP sometimes include administration of rabies immunoglobulin in severe category 3 exposure, in category 2 exposure to the bats, or in immunocompromised patients. So let us come to the pre-exposure prophylaxis. Is a vaccination in preparation for potential risk of exposure to rabies virus. Pre-exposure prophylaxis is recommended for individuals at a higher risk due to occupation or for subpopulation in remote rabies endemic settings. PrEP makes administration of rig unnecessary after a bite wound. So if somebody has taken PrEP, pre-exposure prophylaxis, and he is exposed again, no need for immunoglobulin, only booster doses are required. So previously immunized individual benefit from abridged PrEP in case of exposure to rabies virus. So this is the post-exposure prophylaxis. This is done 2 vaccine shots on day 0 intradermally and then on day 7. So vaccine, all cell culture vaccine are highly safe and recommended by WHO for both pre and post-exposure prophylaxis. Evidence supports administration of cell culture vaccine by intradermal or intramuscular injection. Intradermal administration rabies vaccine provides a cost-saving, dose-sparing alternative. Systemic review of vaccine potency has shown that current vaccine, having a potency of more than 2.5 IU per IM dose, when administered by ID route for either PrEP or PEP, have efficacy equivalent to or higher than intradermal, that of same vaccine administered by intramuscular route. So intradermal is not only cost dose sparing, it is highly immunogenic and higher immunogenicity is there compared to IM route. So we should not waste vaccine and immunoglobulin by giving IM. There should be a bleb. No, bleb is there. 3 to 4 bleb should be there. If it is not, the bleb is not there, then you re-vaccinate the patient in nearby site. So after exposure to virus, rig provides passive immunization and kills the virus by neutralizing in situ. Rig is derived from human source or the animal source. Single monoclonal antibodies are available. So post-exposure prophylaxis, which includes extensive and thorough wound washing at the exposure site, Together with rig administration, if indicated, and the administration of a course of several doses of rabies vaccine. And pre-exposure prophylaxis, which is the administration of several doses of rabies vaccine before an exposure to rabies virus. WHO retains its recommendation that the production and use of nerve tissue vaccine that is not available. Now it is no more available. Both PEP and PrEP vaccine can be administered by either ID or IM, as I told you. ID you have to give 0.1 ml of vaccine on both the deltoid skin, and IM you have to give full dose, either 0.5 ml or 1 ml, whatever full vial has to be given. Entire content of the vial has to be given IM. The sites are in children anterior lateral to thigh, and for adults it is the deltoid muscle. Never give, don't inject in the gluteus region. Vaccine injected in gluteus region is no vaccination. Considered as no vaccination. So any dose is delayed. Vaccination should be resumed, not restarted. So resume the schedule, not restart. A change in route of administration or in vaccine product during a PEP or PrEP course is acceptable if such a change is unavoidable. So one brand of vaccine, next time another brand of vaccine, that is acceptable if there is no other alternative. So these are category 2, 1, 2, 3 that I told that we don't do this categorization in Himachal Pradesh, but the category 1 is no skin surface is not broken. Category 2 is surface is broken, no bleeding is there. Category 3 is there is a bleeding. So in category 1, nothing is to be done, only washing of the part. Category 2, wound washing and vaccination. Category 3, wound washing, vaccination, and infiltration of the wounds. And when any person who has got a post-exposure prophylaxis or pre-exposure prophylaxis is again exposed any time in life, he would require only booster doses. And booster doses are one site ID on day 0 and 3. Similarly, or one site or 4 site ID in same day you can give, or one site IM on day 0 and 3. So they are the booster doses. So, but that already explained. Category 1, 2, 3, wound washing is most important. Rig should be administered only once, preferably at or as soon as possible after the initiation of PEP. Rig is infiltrated into and around the wounds. For optimal effectiveness, the maximum dose calculated by body weight should be injected into the wound, and if the wound is small, then don't inject the remaining immunoglobulin IM away from the wound. Skin testing is not recommended by WHO. Even if a rig is not available at the first visit, rig can be given up to 7 days after the first rabies vaccine administration if it is not available. So give the vaccine, send the person to the higher center. Similarly, pre-exposure prophylaxis, I told 2 site ID administration on day 07 and 1 site IM administration on day 07. So these are the pre-exposure prophylaxis recommended by WHO, and these are the future recommendation. What future research is required at the global level? That are the research questions that you all can take up one by one and take research on these things, these recommendation. Thank you.
Thank you, sir, for this
Thank you.
another wonderful presentation, sir. So, sir, we have some questions again. So,
Yeah.
sir, the first question is, how does the WHO classify the severity of exposure to rabies, and what action are recommended for each category?
See, that I already explained. The severity is type 3 wound or severe wounds. The bleeding is there, or the mucous membrane has been contaminated by the spillage of the rabies virus. So these are the severe category wounds, and they require thorough wound washing, vaccination, as well as infiltration of immunoglobulins.
Then, sir, the next question is, how does the WHO recommend managing rabies exposure in individual with previous rabies vaccination history?
That's also I took up giving boosters. So booster can be given by intradermal or intramuscular route. Intradermal, one shot on day 0 and 3, and or all the 4 shots on the same day. So intradermally, and intramuscular, one shot intradermal on day 0 and 3. That is the booster that is to be given.
So there is one last question. What are the current recommendation for rabies immunoglobulin administration in different exposure scenario according to WHO guidelines?
Yeah, that's what I told you, that only wound infiltration is recommended. So yes, if the wounds are lacerated, too many wounds are there, then we calculate the immunoglobulin by weight, and we don't exceed that volume. And still, if volume is required, then we dilute those immunoglobulins equally with the normal saline, and then infiltrate all the wounds. So that is what the recommendation is. In giving intramuscular this thing immunoglobulins is not recommended.
Thank you so much, sir, for answering all our questions. That's all from our audience, sir. So, sir,
Thank you.
before concluding, any take-home message from your end?
See, take home, as I said earlier, the take home message is rabies is everywhere. So don't be complacent like my seniors were there in Shimla, that there is no rabies in Shimla. So when I tried and searched, then I found all the animals rabid. I found many people, exposed to rabid animals. So don't be complacent. We are a rabies endemic country. Maximum, we should all, especially doctors, should get pre-exposure vaccination, so that at least on exposure we can take boosters. No painful immunoglobulin infiltration is required. So that is what I want to say. And for patients, wound washing is important. 60% rabies can be prevented by only wound washing and application of antiseptics.
Thank you so much, sir, for joining us today. With your permission, sir, I would like to conclude today's session. Thank you.
Thank you. Thank you for giving me this opportunity.